All right. Hello, everybody. My name is Garrett Child. I'm a third year physical therapy student at the University of Mary. I should have met everybody in the department by now, but if not, this is my third rotation, and I'm doing an acute care rotation, and my CI is Hunter Stemmer. So for my in-service, I decided to present on the current evidence for COVID-19 in the acute care setting. So I kind of noticed a need for this throughout my time, my first 8 weeks at Billings Clinic. I think some therapists are um, just a little confused on when to step in and when intervention is needed for these individuals, especially when there is such a wide variety of current clinical presentations with each patient. And so I decided to try to look into the current evidence and try to find if there's a better clinical practice guideline or specific guidelines on when we should be intervening. And I think I did a decent job at finding some of the current evidence, but this is obviously a very evolving disease, and more research is needed daily on when we figure out what the pathogenesis of this disease specifically is. One just disclaimer about when researching into COVID-19, there's a lot of great research coming from other countries, specifically like Australia and United Kingdom, but because they've had this disease for a little bit longer than we have here in the United States, but we some of the research that I found, it varies on the clinical practice guidelines just because they have a different scope of practice for therapists than they would here in the United States. So some of the pathogenesis information was very relevant that I found, but the specific recommendations might be different just because of the different scope of practices. Um, all right, let's get started. The objectives for this presentation is to identify the benefits of a rehab professional working with patients diagnosed with COVID-19 within the ICU, identify red flags, symptoms, risk factors for further disorders in patients diagnosed with COVID-19, and the ability to formulate treatment plan ideas based upon current functional status in patients diagnosed with COVID-19. So the first piece of evidence that I jumped into was by Spruitt et al. This is a survey completed by both European Respiratory Society and the American Thoracic Society. So this is a trans-countryal study through Europe and America, and it was a survey completed with 76 experts in pulmonary rehab / respiratory critical care. 92% of these 76 experts recommended that patients should receive rehab at bedside until discharge when a patient is admitted in the hospital. So early rehab showed to slow both physical and emotional deterioration. 92% of these experts recommended O2 requirements, so supplemental oxygen should be assessed at both rest and exertion prior to discharge. And this is a perfect place for a therapist to step in and complete this assessment. 81% recommended low to moderate activity 6 to 8 weeks following discharge, so this would step into the outpatient setting. One of the main reasons to continue these is that there's a very high inflammatory burden in COVID-19, and we'll kind of get into the pathogenesis of some of that inflammation later in the presentation. 97% of the experts recommend that physical function assessment be within 6 to 8 weeks following discharge, and 98% recommend lower extremity muscle mass strength training. So this is kind of getting into the fact that says acute care therapists should recommend that patients receive outpatient care following discharge, and we can kind of begin that once we're doing our discharge protocol and our discharge disposition, and make some recommendations to the patient that outpatient physical therapy or occupational therapy could be a great idea for them to continue to do once they're discharged. So then the study kind of went further into some more treatment protocols, and they jumped into the effects of prone positioning. So prone positioning obviously is putting a patient diagnosed with COVID-19 into the prone position instead of the typical supine position. This allows for homogeneous lung pressures, uniform alveolar size, and improved ventilation of posterior lung fields. So both lungs are now able to exhibit the same amount of pressure. Alveoli are allowed to expand to the same size, and the posterior lung fields are now allowed to expand. They're not blocked by being in a supine position in the bed. This overall has improved oxygenation. It has been shown to reduce mortality. One of the main drawbacks is this is a complex transfer to get a patient into prone, especially when there are many lines and tubes involved. And some of the problems with this could be a displacement of these lines and tubes. It could cause some temporary hemodynamic instability. Could cause some nerve injury and corneal abrasions, and it could cause integumentary breakdown on the anterior portion of the individual, as prone will then increase the pressure on the anterior portion. This study stated that rehab therapists with ICU experience have the perfect amount of training and expertise to perform these maneuvers and should be involved in these prone positionings. In the second piece of evidence that I found, the study goes on to show that a specific hospital, Brigham and Women's Hospital in Boston, started a prone team. This was a team, specifically their job was to put patients into the prone position. So this hospital is a pretty large hospital, 793 beds, about double the size of Billings Clinic. So what is the prone team? The team is comprised of PT and OT, and these individuals have to have ICU experience, and they are also treating along with respiratory therapists and nursing. The prone team's job is to ensure safety of the patients throughout the transfer. Whenever there was a position change that did occur, it required one nurse and a respiratory therapist and the prone team be there. So kind of the protocol for putting a patient into prone, the physician orders the chart, the timing, and is in charge of when that will occur. The prone team is there to screen for further limitations and to screen vital signs as the change in positioning occurs. Over 7 weeks that the study occurred, the prone team was consulted 934 times to make this prone change, so they obviously were very much in need. This is a diagram that the study included. Please feel free to pause the video and take a look at what they decided for criteria for prone therapy. The first of all, they kind of get what specific respiratory settings were present to complete the prone therapy. There's also indications for winter return. And one of the main things that I took away from this study is that suggested time in prone was greater than or equal to 16 hours per 24 hours. So that just indicates how important getting into the prone position really is. This is another diagram you can go ahead and pause the video to take a better look at. And I'll also have my email at the end of the presentation, which you can email me if you have any questions about this, or if you want to take a better look at these diagrams, and I can send them to you, or I can send you the whole study if you would like. So this just kind of looked at the specific roles of what each individual of the prone team would do. So specifically would look at positioning and monitoring and looking at the vitals and assessing and preparing the integumentary system, organizing lines. I think this would be a perfect job for a physical therapist, occupational therapist with ICU experience to kind of get more involved with creating a prone team, as there's no really other profession that has the experience to complete these complex maneuvers, all while assessing further limitations present in these patients. This is a little flow chart on their different assessments they did throughout the proning session. It kind of starts with the nurse and the medical team saying it's time to start the proning session. Respiratory therapy is called, supplies are organized, the use of sedation or neuromuscular blockers are assessed, and deciding if any change in medication needs to occur before this complex proning position is changed. RT is then there. The The prone team is also there. The patient is pressed into the prone. The prone team is in charge of then making sure all the devices are in the right place. Vitals are continually monitored. And then some of the main things that the prone team was due at the end is make sure that the cervical spine, upper extremities, and lower extremities are in an optimal position to prevent any integumentary deviations down the road or any excessive pressure ulcers that could occur from this positioning. So the average length of the session to perform this was 20 minutes, so it's really a pretty quick maneuver. It wouldn't take too much out of the day to really just perform these proning sessions, and there's some great evidence to show that it really does help the patient. So the next study I look at was by Shankes et al. This is the use of sedation in patients with COVID-19. So I decided to look up why sedation is occurring and if it's just purely for patient comfort or if it's just necessary for patients to not cause further damage to the supplemental oxygen they are receiving through whatever form they are receiving it through. So this study suggested that prone positioning does occur when patients' PaO2 for FiO2 ratio is greater than 150 millimeters of mercury. So the use of sedation in patients improved gas exchange, respiratory system compliance, and lung protection. The main drug they used for sedation was propofol, in which we see commonly in Billings Clinic. And the goal of the sedation was to increase patient comfort and safety, facilitate the life-saving interventions, and maintain interaction with staff. And this has been shown to allow for earlier physical recovery. So the main thing I took away from this article was that sedation isn't only used to keep the patient from removing any part of the supplemental oxygen that they are typically using or just keeping them overall safe, but it also has increased respiratory system ability and earlier physical functioning. The next research I looked into was by Johnson et al., and they specifically looked at PT interventions within the acute care setting, and they connected the relationship of number of physical therapy visits with mobility status after the discharge. So the study looked at a total of 312 patients from 11 hospitals. 46.8 of these 312 patients were discharged to home, and the rest were discharged to another facility, such as a skilled nursing facility. So the study found out that with the increasing number of physical therapy visits, increased the likelihood to discharge to home. So the probability to discharge to home when someone saw PT every other day was 45%. That number jumped up to 60% when PT had a visit every single day. So overall, increasing visit number and visit length really increased the ability to discharge to home and also increase mobility prior to discharge and once after discharged. So there was a statistically significant AMPAC 6 clicks outcome measure, which we do perform, increase when patients were seen more and seen for a longer length. So that increased almost 2 points going from seeing just once per day from every other day to once per day. And every additional 10 minutes seen with a patient increased this 6 click score. This just means that increasing visit numbers and increasing intensity really increase these patients' ability to function with mobility and be able to discharge to the home. So this was a next study by Whittemore et al., and they looked into the use of awake proning, and this was a case study. So this was an individual, 60-year-old male, COVID-19, had a total 18-day hospital stay. He was treated with a 12-liter per minute non-rebreather mask, and he was having desaturation episodes into the low 80s when in supine. When he would flip over into prone by himself, this wasn't a dependent or even any assistant needed transfer for him to get into prone. But once he did get into prone, his saturation jumped up to 94%, purely by switching to prone. They set some parameters for how long he should be in prone and up to 18 hours per day. No sedation was needed for this patient, but that's where he received the greatest amount of effect from proning was when he was in prone 18 hours per day. So this just shows that we can be able to educate the patient on what proning can do for them when they're on any form of supplemental oxygen. How it can really increase those posterior lung fields to be able to get more oxygen into those posterior lung fields. It can really allow for those increased saturation. So this was a study I looked into. Something I kind of noticed at my time at Billings Clinic was these return of patients who had been diagnosed with COVID-19 who are coming back with orthopedic injuries such as fractures. So I decided I was just going to see if there's any further evidence for why these fractures would be occurring in someone who was diagnosed with COVID-19. I did find a systematic literature review who had a total of 984 patients. The most common fracture following COVID-19 was a proximal femur fracture, which is also the most common fracture following a fall. So the study didn't go into specifically, but I think there is a link between falls and um, the diagnosis of COVID-19 following discharge from the hospital. So overall weakness and overall balance decline is probably evident in these fractures. So the mortality rate of these hip fractures grew from 2% when not diagnosed with COVID to 36% mortality rate when COVID was a diagnosis in these patients. So that's a massive increase in mortality rates when a hip fracture does occur. This is also further increasing when surgical fixation has to occur in these patients. They didn't have a specific reason why this is occurring, but an estimated cause for this would be increased VTE risk, increased risk for the cytokine storm, and the significant increase of ARDS. The patients are already at an increased risk for ARDS, so once they're going into being bedridden again and having to be on supplemental oxygen again, possibly have surgical intervention, that ARDS risk further increases once again. So this information, I found it to be very important for rehab professionals to look at just because we do have the ability to reduce fall risk. We do have the ability to increase balance ability. We do have the ability to increase strength. We do have the ability to reduce falls overall, and that would indicate that we would be able to reduce mortality in these patients who were diagnosed with COVID. All right, this article I looked at was specific into the neuro rehab of patients diagnosed with COVID-19. So these reports have shown that there is 1/3 of individuals who have been diagnosed with COVID-19 suffer some sort of central neurological manifestations. The most common diagnosis within the neurological field of patients who have been diagnosed with COVID are encephalopathy, encephalitis, cerebrovascular disease, and impaired or altered consciousness. Why exactly this is occurring is not known, but it is the most likely cause is probably from the chronic hypoxic state. So similar to a hypoxic encephalopathy, these patients are not getting an adequate oxygen in and then getting central nervous system dysfunction because of it. It is also shown that COVID has a highly prothrombic state, causing microvessel occlusion. So then adequate oxygen is not getting into the tissues it needs to just because of that vessel occlusion. All right, so some of the ways to decrease the chances of neurological deficit. They found that early mobilization can be implemented during mechanical ventilation and has been shown to counteract weakness and neurological deficits. Verticalization, so not getting out of supine and sitting up, they actually were able to do this with a table, or if someone is too weak and not able to sit up on their own, has been shown to also prevent this deconditioning. There was also a lot of evidence for using a lower body ergometer, which is a bike which is able to be used in sitting or in the supine position, and instead of providing resistance to pedal, provides assistance to FETL, has shown a decreased or prevention of polyneuropathy. And also, they stated that early mobilization has shown increased effects of neuroplasticity, the ability of the brain to change and recover. So, utilizing early mobilization has been the best way to help recover from the central nervous system changes once it has already occurred. This is a little flow chart that the study posted, and it starts with early mobilization and the effects of what it does. The biggest thing I saw is that you were able to get that tracheostomy, weaning, and lung rehab, decrease of supplemental oxygen being used, causing cognitive rehabilitation and overall neurological improvement. And this is all because of the enhancement of neuroplasticity. So this is just a positive feedback loop showing that the effects of early mobilization causes neuroplasticity and neurological deficits are diminished. So they did provide some guidelines on vital signs when completing this neurorehabilitation. And it was talking about how active treatments should be withdrawn and when they should be withdrawn. So they stated that it should be withdrawn with high fever, if respiratory rate was over 30, the FiO2 was greater than 50%, and if pulse oximetry was less than 93% when on supplemental oxygen of some sort. Arterial hypertension, arrhythmias, or shock. Now, this is just talking about active treatments. Mild physical exercise, such as passive exercise, positioning, and respiratory training, could still occur if some of these contraindications are present. It's more about being able to get some rehab in if the contraindications are present and just step away and not perform the active treatment for that day if some of these red flags are present. All right, so lastly for this, they were talked about frequent posture changes, passive mobilizations should be completed if the patient is unconscious. So this is stating that we should be able to prevent any significant pressure wounds and be able to prevent contractures, as these are both present in individuals who are unconscious for multiple days at a time. And with these interventions, we should be able to prevent those further limitations. All right. So this piece of evidence was provided by the APTA, and they provided specific recommendations for acute rehab in patients diagnosed with COVID-19. They started off this research with some ICU contraindications and possible risks to out-of-bed activity. Feel free to pause the video at this point and take a look at some of these. And just make sure that it shows that these are some of the red flags for out-of-bed activities. So make sure we're always monitoring vitals and that this is something that is assessed currently and constantly. And while this is for out-of-bed activities, it doesn't really apply to if we're going to be doing just bedridden activities, supine activities, or bed level activities. Some of the biggest things that I noticed from this were temperature, the inotrope doses, so taking a look at some of the medications being given, the oxygen desaturation, obviously, that we see patients who drop below that, but we need to make sure the 90%, we need to make sure that when it does kind of drop below that, we're taking a rest and letting them return to that before continuing more activity. So then this piece of evidence compared critically ill patients in the ICU versus severely ill patients. So they then broke down critically ill patients into the unconscious and the conscious patient. In a patient who is unconscious, they suggested that respiratory support and active mobilization is not necessarily feasible, as we cannot design many therapeutic goals. This is in lieu unless you're able to be advising on positioning treatments or if you're on one of the proning teams. And it is also not necessarily true that we can't perform goals if contractures are present. If contractures are present, we should be advising passive movements along with positioning treatments and possibly splinting treatments. So, proning teams and prevention slash diminishing of contractures would be two main reasons why we should be working with unconscious patients. For the conscious patient who is critically ill, we should initiate respiratory training and start the prolonged process of weaning from O2 support, stimulate active mobilization as much as possible. We're going to increase exercise tolerance and increase cough strength, perform bed level activities, and constantly monitoring hemodynamic function. So then the patients who are severely ill, who are in a COVID ward instead of the ICU, should complete breathing control exercises and thoracic expansion exercises, active breathing exercises, inspiratory and expiratory muscle training, and of course active mobilization will be huge for these patients. And this is where the O2 precaution now changes and could get to 85%. So obviously we can get a little lower, we can do a little bit more physical activity and just make sure we're monitoring it, but we can maybe push our patients a little more, increase the intensity. We want to keep our perceived exertion rates 3 to 4 out of 10. And if once these exercises are well tolerated in sitting, make sure we're progressing to standing exercises. And they gave specific recommendations for if we are bedridden, bridging activities, rolling activities, and getting to the sitting position has all been shown to be helpful with patients diagnosed with COVID. All right, so then one piece of evidence I wanted to look at and some red flags you can look at for some of these patients diagnosed with COVID is the coagulation of these patients. So one of the main pathogenesis of COVID that individuals have been presenting with is an inflammatory response through the ACE2 receptors, especially arising in the endothelial cells within the vascular system. So because of this inflammation in the vascular system, there's an increased risk of VTE and DVT through the cytokine storm, causing profound systemic inflammation. So 20 of these percent patients who are diagnosed with COVID are presenting with some sort of coagulation abnormalities. This is most common through microvascular thrombosis of small vessels or organs. So this is where the vessels are getting to almost the capillary state where they are getting much smaller, much greater chance for clot, and much greater chance for a hypoxic state at these tissues as functional oxygen is not receiving them from the inflammation at the specific vessel. So 71% of individuals who have died from COVID met the criteria for intravascular coagulopathy, while 0.6% of survivors met this criteria. This shows that many of the individuals who are passing away from COVID are receiving coagulation deficits, drastically increasing the mortality rate. Critically ill patients are already at an extreme risk of coagulopathy, just being sedentary, not being able to perform active muscular contractions. COVID is further increasing the risk and further increasing mortality rate in individuals. So typically, these clots are occurring on the venous side of things, while it is more common in the arterial side in the young. I think we've all seen some of the studies where young individuals have the increased chance of MI and CVA from COVID, and that's where this is coming from, coagulopathy in the arterial side, causing both the heart attacks and strokes in these individuals. So I think just an important thing is always being able to screen and always assessing for any type of blood clots or any type of stroke/heart attack symptoms in any patient diagnosed with COVID. They did provide some recommendations on prevention of coagulation. The most common pharmaceutical treatment is unfractionated heparin. They did suggest the use of intermittent pneumatic compression and utilizing physical activity whenever possible. They did say that aerobic and bodyweight resistive training decreases the VTE risk, and they suggested using the Wells criteria for low extremity DVT. So these are the common signs and symptoms for both DVT and pulmonary embolism. This is some more of the Wells criteria. We need to be really making sure that we're creating active contractions if we can and screening for any of these DVT symptoms, as they can drastically increase patient functioning down the road and can be integral in screening for any further symptoms in these patients. This is a flowchart they provided. It's in conjunction with the previous table on to be able to screen for any further coagulation problems in patients. So, does the patient have any signs and symptoms of VTE? That's from the previous table, and then it breaks down into lower extremity, upper extremity DVTs or pulmonary embolisms. And if any of these signs and symptoms are present, it's stating to consult the medical team. And as soon as the medical team is consulted and they are medically stable / anticoagulated with pharmaceutical treatments, mobilization is needed as soon as possible. So then the last piece of evidence that I looked into was a CPT code created because of the coronavirus pandemic. So in 2020, AMA produced a new CPT code, 99072. It is unclear if this is yet covered by Medicare, but a lot of the larger private insurances it is covered by. This is a CPT code which is applied to recover some of the costs from the coronavirus pandemic. This is for additional supplies, for increased need of PPE, increased sanitation measures, which was not necessarily planned for, and also for some of the staff repayment to complete some of the symptom checks needed to screen patients for the coronavirus. I thought this was just an interesting little thing that the AMA did to kind of bring some of the cost back and get some money back for that we did not see that we were going to have to pay for from this pandemic. All right, that's my presentation. If there are any questions, feel free to email me at gchild1@umary.edu. I should be able to be back around the 21st at the hospital, so you can also bring up any questions to me there. I'd be happy to send any of these research articles if you have any questions on them. Yeah, so I think some of the biggest things is that we can perform interventions with these patients. We just got to continually be screening for red flags such as vital signs, coagulation changes, and neurological changes in these patients. And as long as we are doing that and we are following the current evidence the best we can, which is changing every day, that we're doing the best we can and patients really are benefiting as discharge is being able to be occurring at a sooner time than it was at the beginning of the pandemic, and patients are also more functional when they're discharged once we realize that active treatments and physical therapy, occupational therapy, speech therapy has all really helped these patients out get home sooner and being more functional once they are returned to home. Here's my reference list. All right, thanks everybody.